right side, right? And last but not least is what Dr. Teo has shared in the first case just now, is when we have shock that dilemma. Unfortunately, in cardiology, we give a lot of people objective way to know the patient has coronary artery disease. So people will tell you he has this occluded, that occluded. When you listen over the phone, you will feel very stressed because you cannot deny the patient has heart disease. Okay, so this patient has CABG, has a lot of place occluded, even the graft also occluded over the years. Okay, he's surviving with the single proximal RCA stenosis. On top of that, patient also have some lung diseases, so 2 organs involved here. And he developed chest pain one day and come in with ST elevation of the inferior legs. Okay, so of course we think that the culprit is the one that is solely surviving for him. He has many place block, so they try to PCI the RCA, but they fail. Okay, so the patient ended up in CCU, having non-STEMI with hypotension. Now the EF dropped a little bit further to 40%, and he also coughed up blood and desaturated. So it's multiple problem right now. So of course, unfortunately, cardiac accepted the case. Because of all the lousy vessels, so we cannot deny patient has heart disease. So we now need to deal with the patients, whether the patient is just having a cardiac problem or is there something else behind. Okay, the lactate is very high, 8.5 at the time he comes. X-ray, not too sure whether it's overloaded or consolidated. Okay, just whack everything, noradrenaline, meropenem, pneumonia. Okay, so at this point of time, it's very hard to say whether this is heart or not, or there is some component of other sepsis that dropped the patient down, or is it a type 2 thing? So we put in a PA cath. Once we put it in, you can see that the SVR is very, very, very low. In heart failure patients, the body will try to compensate by constricting the vessels. You can see the SVR a bit higher, but not in this case. The cardiac output, surprisingly, not too bad with noradrenaline at 2.4. Okay, patient is a bit not really very overloaded, but the SVR is super low. So from here, we know that there's something ongoing. It's not the cardiac that is the problem, but probably something that caused the vasodilatory effect. Of course, there's one entity of cardiogenic shock where you let the patient just shock for some time. They also develop vasoplegia in the end. The SVR will drop. That is the point of non-return. Okay, but not in this case. He was early enough to come. We are early enough to try to revascularize and resuscitate him. So something else is ongoing. Okay, so what we do in this case is that we add on noradrenaline and vasopressin. We know that the problem is the vasoconstrictor. If we can increase that, probably the blood pressure will improve further. Okay, so they added on vasopressin and noradrenaline, and you can see that the SVR slowly go up. The MEP also slowly go up. Okay, so there's an improvement of the hemodynamics with the usage of the vasopressors. Okay, so we continue the sepsis treatment. Patient's lactate is improving, and eventually we can slowly titrate off. Patients improve over the days. So with sepsis, you treat early as what we know, septic guidelines. They will usually improve very fast. So that's the last case that I want to share, is that when there's some concomitant thing going on in our cardiac patients, having a number inside for us to guide us will make our life easier in titrating which type of inotrope support. So yeah, those are the 3 cases I'm sharing. I thank you for your attention.
Yeah. The cell of Bedouin. Yeah. Thank you.
Oh, thanks.
Thank you, Dr. Ling, for sharing his Singapore experience. I believe all the IJN team is still down in. Any question for Dr. Ling from IJN?
Dr. Doswa, if you don't mind, can I comment on something?
Yeah, you can, Dr. Teo.
Yeah, I think, thank you, Dr. Ling, for the very nice case presentation. In fact, this is very enlightening to me, you know. His cases is, I must admit, is greater than mine, I would say. Yeah, so my comment is to the first case. If you still remember all these parameters that Dr. Ling have obtained via the Swan gun catheter, is basically, I must agree that, you know, this patient is having a advanced heart failure. You know, when you are trying to titrate up the guideline directed medical therapy and you face a lot of problems, or for example, like low blood pressure, you know, and the side effect of the medicine, and or too bradycardic, and then you can't really up titrate them. That is the criteria to you know, consider the advanced heart failure treatment. Of course, the so far the heart failure advanced heart failure treatment we have is kind of like you know, I would say very difficult to assess to. I would say it will be a left ventricular assist device, the heart transplant. Of course, if they are ineligible, then we think of a palliative care, and some patients don't mind to go through the experimental, you know, therapy. And talking about this advanced heart failure treatment, there's some other parameters that I think we should, you know, look at when you look at their result, especially if the patient got a mitral regurgitation. You know that mitral regurgitations tend to overestimate the ejection fraction. You know, if the patient got 25% of ejection fraction in the presence of the MR, I would say the EF is lower than that, if you agree with me. And this even worse if the patient got atrial fibrillations kicked in, then I think the patient is going to deteriorate very soon and have a frequent hospitalizations. So in a patient with the MR, with the atrial fibrillations, even though the EF is roughly very good, like 35%, you might also, you know, consider to treat aggressive this group of patients. And I think your case is very nice to me. I would say the initial, the PVR is rather high, you know. It's around 3.2. And after you start the Murinon, the inodilator, you can actually demonstrate that the PVR actually dropped to 1.08 and 1.85. This basically it demonstrates that with the inodilator, you can actually reverse the pulmonary hypertension. In fact, this is so-called the indirect vasoreactivity test to show that, well, this patient's pulmonary pressure is due to the left heart disease and is fully reversible. And basically, in this group of patients, sometimes you are thinking, let's say this patient is younger, right? With the PVR of more than 4 or 5, sometimes the surgeon will say, these patients, we have to do the heart-lung transplant. But if you can show the PVR is reversed with your vasoreactivity agent or even with your treatment of heart failure, then the patient usually can go for the heart transplant alone without the lung. Or if you cannot reverse the PVR, then the patient need to go for the heart and lung transplant. Why? Because if the PVR persistently high with the isolated heart transplant, usually the new right ventricle will fail, and eventually the patient will still succumb for heart failure. So that's why if the PVR is too high, the surgeon will think of heart-lung transplant. And definitely there's a difference between the heart-lung transplant versus the heart transplant alone. You know, the heart transplant alone patients, the median survival 10 years, no issue. But if you talk about the heart-lung transplant, not only you need to have more organs for one patient rather than giving 2 patients, the life expectancy of heart-lung transplant is shorter, around 5 to 6 years. So this is very important. Of course, this patient is about 63 years old, if I'm not mistaken. I think the best thing for him will be the LVAD as a destination therapy for him, because you know the cardiac index is really less than 2, and our cutoff point for this LVAD is actually 2 at least. So with the inotrope support, you see it's very difficult to get it be above 2.0. So I said, you know, the other comment will be, yeah, I think it's very nice when you start this Murinon is, you can see there is an improvement. And in my practice here in IJN, you know, cost is still a concern for us. So I won't try with the Murinon, but I will try with dobutamine. Let's say the patient responded very well to dobutamine, then I will switch straight away to the levosimendan. Like what you say, the half-life is longer. Hopefully the patients can last longer outside the hospital. So sometimes I'm thinking about, if you look at this patient, most likely this patient is inotrope dependent. He need inotropes. So I'm thinking maybe you can give the pulse levosimendan, like monthly levosimendan, and some patients are even put on the home inotropes, you know, continuous infusion for them, to actually provide the, you know, better quality of life. And talking about the inotrope response to the patients, each of the patient will be respond differently with inotrope. Some maybe you use a single inotrope and responded very well. Some you use two or three is still not responding well. It basically depends on the residual viable myocardium. You know, if the patients have infarcted myocardium, a big portion, you don't expect a single inotrope can, you know, give the patients good response. So you need more than that. Yeah. And I agree totally that I think no beta blocker for this group of patient, because as you can see here, the cardiac index are really low. If you start the beta blocker, of course, trials say that longer survival, but what if longer survival without the quality of life here? You know, the beta blocker can actually make the patient feel lousy, and sometimes it will drop the cardiac output further, and the patient will have a more, you know, heart failure symptom rather than good quality of life. Yeah, I think that's my comment for the case number 1.
Thank you, Dr. Teo, for the comment. Dr. Teo, in your experience, how many pulse levosimendan have you advocated? Is it easy to be done, or?
Regarding the pulse levosimendan, basically, I usually do it kind of like a symptoms based. Once the patient feel not not good, they feel very lousy, or they feel there's a leg swelling or reduce in the effort tolerance, then usually I ask them to come in, give a dose, and then they go back again. So this is what my practice now. I think there's one patient currently under my care. Every month I'm giving his levosimendan, but again, you know, the cost is always the issue. 1 mp of levosimendan costs you about
6,000.
3,000, I guess.
Oh, okay.
Yeah, so that is also it is a, you know, cost consideration. How many patients can afford this 6,000 a month? Let's say you say it's 6,000, so how many of them can afford? So if you ask about those cheaper way of treating patient, will be the continuous dopamine or dobutamine. By calculations, I think a month need about 500 ringgit Malaysia, including all the consumable. You know, if you use a syringe driver lah, don't use a hi-fi infusion pump, or that one is, you know, the patient can't really afford. Yeah.
How about pulse dobutamine? It doesn't work as good as pulse levosimendan, right?
No, like what Dr. Ling pointed out just now, the half-life play a very important role here.
Yeah.
Half-life of levosimendan is about 80 hours. Half-life of the Murinon 2 to 4 hours. If you talk about the dobutamine, 5 minutes. So, you know, by the time patient walk out from your ward, the dobutamine is no longer in the body already.
Yeah. Okay. So left with home dobutamine lah. So or pulse levosimendan for this group of advanced heart failure. Huh?
You can think of the LVAD. Yeah, that would be, you know, perfect.
How about this group of patients? Should we refer to IJN for LVAD or any channel that we can? Because in Sarawak we do have quite a number of this group of patients.
Yes, of course, I would say that it is possible, because now we are having the funding, you know, to do LVAD for patients. So our funding is still, I would say, adequate. You know, the only thing to me will be the logistic. you know, always.
Yeah.
So let's say the patients have the LVAD and then go back to Sarawak. And most of the time when the patient had problem, then I would say, you come over to IGN. They say, huh, so far. So they can't
Okay.
come. So that is a problem. I say, you go to Sarawak Heart Center, look for this Dr. Joshua. I actually don't mind sharing the experience and the how do you take care of the LVAD. Because now we are doing LVAD for a lot of patients from different stage, you know. So I'm looking forward, you know, to actually can we, you know, have a, you know, kind of a continuous education to teach, you know, how do you take care of LVAD? Not necessarily, you know, patient to come back to IGN, especially they're staying so far. So once we have the patients over your state, maybe we can go away and then teach you how to take care of LVAD. Because the patient and LVAD, usually you no need to worry about the left ventricle anymore. It's kind of just a normal person, you know, the pump is helping the left ventricle, so there's no issue. To me, the concern is the patient presented to your hospital if hypotension, right, the LVAD. The only two things, either they are lacking of water, hypovolemic, or they are having sepsis. So what you need to do is just pump the fluid in, or if they're not responding, and start the vasoconstrictor. Usually they will respond quite well because the heart is being supported, you know. Yeah, but a lot of people are not comfortable, you know, say, oh, you go to IJN. So it take a long time for the patient to come to IJN. No? So there is things we should look at. Maybe you start your center with the LVAD, Dr. Joshua and Dr. Ling.
I mean that's one of our aim lah. But Dr. Teo, I want to ask performing the right heart cath in patients with like recent LBBB pacing, things like that. I mean, to your experience, is it all right?
Yes, it's all right. Just that you need to be careful, not to induce any not to, you know, stimulate the right ventricle so much. So, I mean, this is also the same apply to the CCU patient. If they are pro-arrhythmic, you know, if they are tend to have a lot of PT, then you need to be careful with the catheter. Don't try to put in blindly, but under fluoroscopy. Because sometimes you stimulate the RV, it will go into PT and the patient will just collapse during the swan gun insertion. Yeah,
Okay.
so I would prefer it to done it not blindly because, you know, some of the doctor will say, hey, this bedside patient difficult to move, you know, so many electrodes, so they do it blindly. Sometimes it can be quite dangerous, you know. Yeah.
Okay.
Will it easily dislodge the ICD or the pacemaker lead?
That's why if the patient got the ICD, let's say a long time ago, then I would say no problem now, just go in. But preferably under fluoroscopy to prove that you didn't dislodge anything. Otherwise, the EP will coming to look after you.
Yeah.
Yeah.
Okay. Okay. Thank you, Dr. Teo, and thank you, Dr. Ling, for the sharing. Hopefully, we can continue to have this kind of conversation, Dr. Teo.
Yes, of course, sure.
Thank you, Dr. Teo.
Yeah.
Okay, see you soon. Bye bye.